Fabulous.
Oh, here we are in the Canary Islands, 4th annual Trending Topics in GU Cancers. You were asked to give a talk on what's your big idea, and you came up with a big idea. I'd love to hear about it.
Wednesday night, I woke you up in the middle of the night with my big idea, because I was under a lot of pressure. And I came up with the Uromigos score. And the Uromigos score scores individual treatments, and a score between 0 and 3, 0 being inappropriate, 3 being the standard of care, 2 being an appropriate treatment but not the standard of care, 1 inappropriate but could be considered maybe.
Yeah.
And we asked, over the last 48 hours, 20 experts around the world how they would score it. We combined the scores together, divided by the denominator, and got a mean score for each individual. We can assume that this treatment is widely available and there's no financial risk.
No contraindications. Okay. So it's really a clinical guideline. What are people actually doing in clinic for treatment A, B, or C? Okay.
And there are advantages over level 1, 2, or 3 guidelines, because those don't really give you much detail, and sometimes the NCCN gives long lists. And
this prioritizes treatments.
And what clinicians are actually doing on the ground.
Let's talk about frontline advanced urothelial cancer.
Yeah.
What'd you find?
So we found that, by the way, thanks to the people who did it. It's really short notice, and it's around the world. We went from China and Japan all the way across, of course, to the west coast of the United States, with Europe in the middle, and we had Asia. We had Turkey.
Global input.
EVP, unfortunately, vedotin pembrolizumab, scored a 3 for everyone, absolutely standard care, which was relatively straightforward. And then avelumab, maintenance avelumab, and gem-cis-nivo. They scored a lower score. They were both at about the 2. They weren't 2, they were 1.5, which was 1.5, and you can see on the screen, 1.5, between 1.5 and 2. So half the people thinking appropriate, but not standard care. The other half, not really appropriate anymore. And I think that, so 1.5, I think probably most people think we shouldn't really be doing this. Should be giving EV pembro.
I thought they would score a little higher. But the strength of EVP sort of knocks them down, if you will.
Yeah, I think the difficulty is if you've got patients in front of you and you go, I'm going to give you gem carb and then adjuvant avelumab. That's the EVP will leave in the cupboard for later. That doesn't feel quite right. So I'm not super surprised.
And it is one or the other when it comes to treating an individual patient.
You can't say, well, we'll give the avelumab later. So I think that's, and then of course, the next thing we went on to was we asked a slightly different question, which is if you can't have ADCs and you can't have chemotherapy, how appropriate is pembro or atezo in PD-1 positive patients and in all-comer population? And this is much lower level evidence. So the trials were negative, and they weren't actually tested in this population because it was the gem-cis, gem-carbo population, because you had to be eligible for that in the randomized trials, although there is a little bit of data in this. And actually these scored quite highly. They actually scored higher than maintenance of avelumab and nivo, and the reason why is because they're not competing with anything else. They're not competing with EV pembro. So they boost up and they're scoring 2, which is an appropriate treatment. And interestingly, in my opinion, the biomarker makes no difference. Now, as you know, we've been talking about the biomarker being a hopeless for ages, and that's what we showed here too.
And I mean, for these patients, they really don't have many other options. So it is reasonable, even if the data isn't as compelling as some of the randomized phase 3s. So we'll build on this. We'll see how it evolves over data sets and meetings, but it's a flexible thing, right? This is one snapshot in time. The state of the art now, but obviously after ASCO, after ESMO, this is going to change. Yeah,
if a big positive trial came out in this space, or suddenly EVP moves in the neoadjuvant space, all bets are off. And then we've got a new score.
Great. Okay. Awesome.